Thank you very much, Andrew. And can I welcome the panel of speakers onto the stage as well, because I'm about to introduce you all, and it'd be great to have you up here. So, Sara online, and Mike Inouye, Cathie and Simon. And just while they're assembling, I'm Cathie Sudlow, I'm Chief Scientist of Health Data Research UK. It's really great to be at such a fantastic, large, in-person meeting. These still seem relatively unusual, I think, but we must remember we've got 1,000 people who've joined us online, and we're going to engage them very much in the conversation as well. So we've got a really exciting panel session to kick the day off on the grand challenges in data. And I don't know what the speakers are going to say, but they've all got 10 minutes to wow you, and then we will have some time for a discussion afterwards. So make a note, those of you joining us online and those of you in the room, of things that you would like to ask. And if we don't get through it all, of course, that's exactly what the coffee breaks are for. So just let me give you the rundown of who you're going to be hearing from. So we're going to hear first from Sara Khalid, who's Associate Professor and Senior Research Fellow in Biomedical Data Science and Health Informatics at the University of Oxford, where she leads the Planetary Health Informatics Group at the Centre for Statistics in Medicine. And if you don't know a lot about machine learning, artificial intelligence, and the importance of dealing with inequity and representation in the data, dealing with those issues, then hopefully by the time you've heard from Sara, you'll know a bit more about that. And then we're going to hear from Professor Michael Inouye, who's Professor of Systems Genomics and Population Health and Director of Data Sciences at the Baker Heart and Diabetes Institute at the University of Cambridge. Mike is an amazing scientist. He's been behind many initiatives, including work on the polygenetic risk score catalogue, multi-omics prediction, and green algorithms. So we may hear about some or all of those. Then we're going to hear from Professor Katie Harron, who's Professor of Statistics and Health Data Science at University College London and Great Ormond Street Institute of Child Health. And Katie's been a real champion for linkages at scale between data from the health system, the NHS, and data from the education system. So non-health, but health relevant, and health data being linked together at scale to derive new insights. And hopefully we'll hear from Katie a little bit about that work and about eChild. And if you didn't hear about that, hadn't heard of that before, you'll know all about it. And then we're going to hear from Professor Simon Thompson, who's Professor of Health Informatics at Swansea University, where he's Chief Technologist and Systems Architect with huge amount of experience of working across the NHS and academia and bringing value through the secure anonymised information linkage platform SAIL in Wales, but also offering services through the extension of that platform as the UK Secure Research Platform Service to a very wide range of other national and international data sharing and data access initiatives. So I really look forward to hearing what you guys have got to say, but we're gonna kick off as quickly as possible, and I'm going to hand first to Sara, who's online. So Sara, take it away, please.
Thank you very much, Cathie. It is a pleasure to be back at the HDR annual conference, there in person. So I have basically taken on the task of presenting a sort of a bird's eye view of how better data and models can lead to better healthcare, although I dare say I can't do a better job of it than Andy has already done. So, and I'll start by saying, as we've all heard it said, in fact, just from Andy just now, that we've entered the era of big data. In fact, as the cover story of this magazine, The Economist, claimed well over a decade ago now, we're constantly being flooded by data, where billions and billions of gigabytes are generated daily. And big data is a bit of a misnomer, since in pure statistical terms, sample size is all relative. But one thing that is for sure is that data are definitely getting bigger. And it's actually because of all of this volume and variety of data that we now have chatbots and other large language models in our everyday life nowadays. And here's a more recent cover of The Economist, so you can tell that I'm a fan. And nowadays, data are being called the new gold. Why is that? Because as we'll see throughout the conference, data can help to fulfill our need for knowledge, to support our decision-making, which as humans is precious. And in healthcare, where is all of this big data coming from? Well, essentially everywhere. So electronic health records, digital wearable devices, genomic imaging registries, and so on. And as one can imagine, this does mean that there are several challenges, both around the collection and curation, and then fair and safe use of these data. So in turn, if these considerations are not handled properly, data can easily mislead. So just to begin with, many of these electronic sources on the screen can mean that those on the wrong side of the digital divide can be left out. And this sort of issues around inequalities or disparities in health is something that was recently highlighted by the COVID-19 pandemic, where people from ethnically diverse backgrounds here in the UK and elsewhere were disproportionately affected. But we know that this inequity is not limited to emergencies. It's a long-standing, global, in fact, multifaceted issue, and that does come with the economic and human cost. So I'm going to give an example of how this is contributed to by AI technology, for instance, for that of clinical risk prediction. Now, as many of us in the room know, this is something that involves routinely collected anonymized patient data. These are then fed into an AI model, which in turn produces a health risk score for a patient. And that can be used by healthcare providers to decide patient care. If there's bias in the data or bias in the modeling processes, potentially doctors and healthcare providers can end up making wrong decisions, and patients could get the wrong sort of care. Now, this bias can creep in many different ways. So first, in the data itself, the issue of health data poverty. So this is where the underlying data may not be representative of everyone in the population. For instance, measures like self-identified ethnicity and other data that reflect population diversity, these may not be correctly or even completely recorded for everyone, and that leaves gaps in the data. Secondly, the issue of algorithmic bias. So considering some of the mechanisms of this bias, race correction is a common one. And this is a well-publicized issue across the clinical spectrum, from heart health to childbirth. And then another example of modeling bias is the use of proxy predictors. Now, this is a famous case from some US claims data, where healthcare cost was used as a proxy for ill health to predict healthcare needs. Authors claim that without such algorithmic bias, over twice the number of people of color could have actually benefited from better care at the point of need. And so there's indeed a long list of models with such biases. In fact, a study conducted by our own department at the CSM in Oxford found that most prediction models today are at high risk of such biases, and therefore not really suitable for triaging patients in actual clinical practice. So such assumptions can lead to oversensitive models, but more importantly, misestimate real people's health risks. And at a society level, some groups of patients can be inappropriately over or under prioritized. And this is something that obviously can affect patient and public trust. So circling back to the challenges before us today, such is the power of health data and AI models, or in fact, a combination of these two. So for myself as an engineer, it's almost a case of reverse engineering in a way where to fix the sort of inequity via data and AI, we first have to get good data on everyone. This is something that Andy was alluding to in the opening. In fact, as this work illustrates, it's a sort of positive feedback loop where, or in fact negative, where lack of access to healthcare in the first place can lead to a lack of representation in healthcare data. So what are the opportunities then is there to address some of these sources at, some of these biases at source? And so in this recent national core study on ethnicity, equity, and AI, the aim was to do just that, to start at source by studying biases within recorded ethnicity information in UK health data with regards to their completeness, consistency, and issues around granularity or detail. And of course, in doing so, one of the key considerations is safe use of data. So this is something that is becoming easier and safer to do through trusted research environments and secure data environments. So through secured access to the NHS England TRE, it was possible to study over 60 million anonymized GP records from just England. Through these data showed that something like over 250 medical concepts for ethnicity are actually used in clinical practice, although over 480 available ethnicity categories exist in the data. And these ethnicity groupings can vary in terms of their size, their detail, and overlaps. But importantly, in agreement with some of the latest census estimates, it was found that the largest ethnicity groups in these England data were indeed white, Asian, Black, and then mixed. And also that secondly, it's possible to study subgroups within these broad groups, as well as those grouped within the category called other ethnicities, although these numbers on the screen are just for England. But as we're talking about real world data, despite the large sample sizes, there's still gaps in the data. So instead, we can look deeper into the data through linkages. In this case, linkage with hospital records helped and reduced the gaps in ethnicity data to 1 in 10 individuals having missing ethnicity information in their health records. And generally, this messiness was found to be more common in the south and southeast of the country, of the region. On the whole, this does exceed historical rates of completeness of ethnicity data when it comes to real-world health data sources, both in England and internationally. But the question is, why is it important? Why are these data important? So with over 250 ethnicity groups found in health data in the UK, the population is clearly diverse and with potentially different health profiles and needs. So grouping everyone into one size-fits-all AI models is sometimes, and this data mining has shown that researchers can study ethnically diverse groups in the UK in detail now. Now, this sort of thing can be important to understand the disparities, and here we see an example of disparities in COVID-19 mortality during the pandemic. And then importantly, to go towards closing some of the gaps in the outcomes. So as we see here in this work showing intersectional disparity in cardiovascular disease, which was narrowed but not necessarily closed through the course and after the pandemic. And then also these data have started to enable predictive tools that are tailored to different ethnicity groups to be developed. So this is all, of course, the story for UK data. But what about data from elsewhere in the world and some of the challenges around that? And the fact is that much of the research-ready sources available to us today as researchers represent a somewhat skewed section of our world. And this skew was nicely illustrated by a global review of over 200 data sets, where it was shown that data disparities exist both within and between population groups, demographics, and across disease areas as well. And of course, given the heterogeneous and sensitive nature of real-world patient-level data from different parts of the world, one can imagine that modeling them also requires robust governance and novel privacy-preserving frameworks, such as, for instance, federated distributed analytics, and where the idea is to analyze or to allow for analysis of multi-site de-identified data simultaneously without any patient-level data sharing. But what this does mean is that these sorts of approaches require first harmonizing data to some sort of common data model. And now this is a slide that I won't say much about, except to draw your attention to some of the complexity of this process and also to some of the scale. So on the right of the slide is work done in Brazil and Pakistan on mapping some of their data to the OMOP common data model. And this is here just as an example to show that some of the ways in which data from places like South America and South Asia, together home to a quarter of the world's population, can be better represented in the global canvas, which will be important in future times. So with this, there is a real opportunity here to bring together data from different in ways that are not done before and data that have not been seen before. And as we know, international data from all over the world was pivotal in the pandemic response, and it will continue to be so in future emergencies and shocks. And I'm sure we'll hear about UK data in this space later on during the conference through colleagues. So I'm going to move towards talking about what's on the horizon. And thinking of some of the broader challenges, the reality is that many of the determinants of health are intersectional. So in fact, in our rapidly warming world, we'll need to adapt our healthcare systems to environmental impacts rapidly like never before. And to study these effects, exposome approaches can help, for instance, to study health data, including individuals' deep phenotype and socioeconomic characteristics, but also combined with environmental exposures. In short, this means that one of the key opportunities is enriching data through capturing multimodality or wider information at the individual level, which can make the task of data linkages more complex and challenging. And this is one of the focus areas in the Planetary Health Informatics Lab here at Oxford as well. So finally, as we'll hear from the rest of the panel, real-world data are imperfect. And so this presents a real opportunity for researchers to work together with patients, carers, and health experts to guide it away from assumptions-based research that can exacerbate underlying biases, ensuring that research and innovation is ethical, safe, well-governed, and inclusive. So I'm going to now wrap up by circling back to enabling all of this with better data in the first place. And for that, I'd like to give the last word to one of our patient representatives who've talked to us about this.
I was diagnosed with gestational diabetes in my pregnancy, which meant that I had to go to a diabetes clinic every other week. It was there that I was told that my community was quite prone to diabetes. If I hadn't completed the paperwork that asked about my ethnicity, I would never have known how big a problem diabetes is in my community and received the care I needed.
So with that, I'm going to thank you and hand it over back to Cathie. Thank you.
Thanks very much, Sara. Okay, we're going to do a very slight rearrangement on the platform because we can't see the slides. So, Simon, can you just help me move the table forward a little bit so that we can look back and see the slides? Thank you very much. Okay, excellent. And next up is Mike. So, Mike, do you take the lectern?
Great. Well, thanks, Cathie. And so we'll just get going once the slides come up. Great. Okay. Thanks, everyone, for the chance to speak here today. So I'm going to tell you a little bit about our lab's research. We are, of course, interested in the etiology of diseases and to understand that through high-dimensional health and biomedical data. And this slide is really just to impress upon you that biology is complex, it is messy. You see sort of, these compositions and sort of propagation of, brush strokes and signal throughout the canvas, and trying to sort of follow what the artist sort of was thinking is really just in the beholder's eye. And really what we're trying to do with high-dimensional data is to try and understand the process by which this really complex, difficult to understand, messy sort of composition came about. So what does that mean in terms of the actual data? Well, here I'm showing kind of multiple layers of different types of molecules, whether it's metabolites, genes, genetic variation, proteins, et cetera, or, for example, microbiomes, so the organisms, the microbiota that live on us. And what we've been doing over the past few years, particularly through HDR UK, is trying to understand the role of variation within, between these levels, and its role in disease. So we've been doing a lot of research, and there's some citations there, trying to give us a sense about, the genetic basis of disease, what are the role of metabolites in disease, et cetera, et cetera. And I'll give you a few sort of examples of that. But first, I wanted to give you a sense of the bedrock on which our research rests, and that is, foundational tools. So we started out early on by designing some really key things that we ourselves utilize and which we've made available to the rest of the research community and indeed the world. So any one of you can actually go to these websites now and Google and find these things and download sort of the fruits of our research. So first off, we were very interested, obviously, in the genetic basis of research, and indeed, as Cathie mentioned, the polygenic basis of research. And what do I mean by that? A lot of diseases aren't caused by one variation in your genome, right? A BRCA mutation, et cetera. They're caused by many hundreds, if not thousands, of variations that are sprinkled around the genome, and which all sort of sum up into one sort of genetic risk, sort of one number per person. And how we actually calculate that has been a subject of intense research in human genomics for probably about 10 years now. And what one of the sort of the things that was really important there was that there was a real sort of disparate sort of research approach to this. Different people were designing different models to sort of sum up all of these variants and weren't making the actual models available, et cetera. So we actually came up with this thing called the Polygenic Score Catalog, which took the published literature, annotated a lot of the polygenic scores, their performances, et cetera, and crucially made the models available freely and publicly for people to evaluate and to reuse and to establish completely independently their validity. So that's been taken up, it's become a central part of human genetic research. The next sort of thing has been omics-pred, which has really allowed us to go from the genetics to the proteins, metabolites, et cetera, and create predictive models that allow others to be able to predict in these different molecules in their own cohorts and do the downstream etiological studies. And finally, the Green Algorithms project. So this is sustainable data science. It really underpins a lot of what we do. It's our philosophy about how we conserve energy when we train these models and when we apply them. I'll just sort of leave it there because Loic Lanalung, who's also in the group, will be talking to you tomorrow, giving you a lot more detail on that. So just a few examples of what you can do with these foundational tools. So with the polygenic scores, we sort of took this beyond just risk prediction, which is typically what people do, and we started asking etiological questions, trying to understand the causes of disease. And we took these into a cohort, which we have centrally, where we have individual level data on several thousand people, not just their genotypes, but their proteins, metabolites, et cetera. And we asked, what are the downstream proteins that are up or down with high or low polygenic risk? So essentially, the factors, the potential druggable targets you might look for and hit to disrupt polygenic risk. So an excellent postdoc in the group, Scott Ritchie, did this and identified probably about 50 different protein mediators of high polygenic risk of either coronary artery disease or type 2 diabetes. And that really sort of gave us a real sort of a bit of a game-changing perspective on how you can use polygenic scores to understand etiology. I'll circle back to that later. The next thing that we did was, as part of omics-pred, we essentially, so maybe a bit of background, we essentially came up with these models that are based on DNA, but allow you to predict in the genetic component of proteins, metabolites, and RNA in any individual you might have that data. And why that was important was that people they just don't have the resources, the money to go around measuring all the proteins in blood or all the metabolites, et cetera. But what you can do is you can come up with an imperfect estimate of those levels just based on a person's germline genome. And that's really powerful because there are millions and millions of people who are genotyped around the world, but much, much fewer proteomics, metabolomics, et cetera. So this resource essentially allowed us to take those DNA models and be able to predict in proteomes, metabolomes into any cohort around the world. And we made these scores freely available to everyone. One of the things we did with this was not just sort of demonstrate its sort of validity and external validation, showing how it how it validates in different ancestries, which is very important. But we also took it forward into cohorts with longitudinal health records, for example, UK Biobank. So we actually came up and generated a synthetic 500,000 person multi-omic data set based on UK Biobank, and then did the downstream etiological analyses, trying to doing proteome-wide association studies with cardiovascular disease, diabetes, cancers, et cetera, and made all those summary statistics available through OmicsPred. And that has really generated a lot of excitement in the community because it gives people, just a massive treasure trove of biomarkers that can tell you a lot about what's causing those diseases. And this slide is really here trying to demonstrate that we're going to go beyond the data. Maybe this is outside the remit of Health Data Research UK, but especially when you're talking about etiology, you have to enter hand-to-hand experimental combat with your targets. And we're taking steps in that now, working together with many colleagues around the world, particularly Brian Drew at the Baker Institute, who's got a CRISPR validation platform that we can actually look at what happens when you knock down these targets in relevant cell types and look at in vivo phenotypes. So just in the last minute or so, I just wanted to give you a sense of what are the grand challenges for our group, which I didn't actually have any forewarning of Andrew's presentation to begin with, but actually resonate quite strongly with what was said initially. So we are pushing back strongly against bias and inequities in our research. This all depends, and chimes with what Sarah was saying, on the diversity in our own data, and trying to fill in those gaps in terms of underserved populations, non-European ancestries, et cetera, because there's really no way we're going to get over the inequity hump unless we have the data. And once we do, things are going to be a lot easier. Scaling of technologies, data, and methods. Andrew mentioned the data, very critical, but the methodologies, the software that we code is also critical, and how we do that at scale, how we do that sustainably is going to be a major focus of our lab, and is going to continue to be, if not for 5 years, then for decades to come. And also crucially, as we go through and step through our models and our results, we are interested in insights, not hairballs. I think this goes back to the initial slide that I put up, where you can't really glean what's going on in that portrait, that picture, but we are trying to take key individual biological insights and make sure that those are valid, take them forward, validate them, and take them into hopefully therapeutic translation of therapeutics. And with that, that's my talk. Thank you for listening.
Thanks, Mike, very much. And now we're going to hear from Cathie Harron. Cathie.
Oh, okay. Yes, hi everyone. Thanks, Cathie. I'm really pleased to be able to speak to you this morning, and I'm a Yorkshire girl, so it's always good to have an excuse to come back. So we're here to talk about grand challenges for health data, and the grand challenge that I want to talk about is how we are going to use health data to improve the lives of children. The Academy of Medical Sciences last month published a really damning report on the state of child health, and they described the appalling decline in child health that we've seen in recent years. And the statistics really are appalling. So 1 in 5 children now have obesity, 1 in 4 have tooth decay. There's been a huge surge in demand for mental health services. Infant mortality now is 30 out of 49 OECD countries, only 3 other European countries behind the UK. And the number of children living in extreme poverty has tripled since 2019. if we want to be able to build a better future and to combat some of these issues, then one of the most important things that we can do is to invest in the early years. That's when we lay the foundations for lifelong physical and mental health. So how do we do this? Yes, we need good health data, but we also need to think outside of the traditional disciplinary boundaries to understand more about social and wider determinants of health and how our health is associated with other areas of our lives. So the households that we live in, the schools that we grow up in, and the environment, the wider environments in which we live. So health and education, to start, are inextricably linked. We know that children who are suffering from poor health are unlikely to get the most out of school. And we also know that there can be some educational school-level factors that can trigger some of these conditions. So the plot here shows the number of stress-related presentations recorded in hospital admission records according to school term times. And you can see across all of the secondary school ages here in the different colours, there are peaks during school term times and then reductions during the holidays. These stress-related presentations are predominantly for mental health-related issues, so things like self-harm and pain without an explained cause. And they're really common. They affect 2 girls and 1 boy in every classroom. So if we can use these data to identify these early indicators of vulnerability or of mental health concerns, then we can use these as opportunities to implement effective and appropriate mental health interventions that can then ultimately reduce the likelihood of clinical conditions appearing later in life. We also know that the relationship between education and health is complex and it starts early. So this plot is showing the association between gestational age at birth and school attainment at ages 7 and 11. And because we had population-level linked data for all of England, we have the power to look at the additional impact of each week of gestation and show that even born a couple of weeks too early can have a lasting impact on school attainment that persists all the way up until the end of secondary school and beyond. If we can use these data, if we can be better at sharing information across services and organisations, then we're in a better position to inform policies around follow-up for clinically vulnerable children and to ensure that the right kinds of early support are in place to make sure that children are all ready to start school in the best place possible. And then it's also important to think beyond the individual. What is happening within a household and within parents and how that might affect child health. This plot shows the number of unplanned admissions for injuries in children and the pattern that you can clearly see is according to maternal age. But we also know that the first 1001 critical days are crucial for child health and development. So in this study, we looked at the health trajectories of the mother using linkage between mothers and babies in hospital records to look back in the 2 years prior to pregnancy and prior to delivery to identify mothers who had presented at hospital with mental health conditions or with indicators of adversity. So again, self-harm, violence or drug and alcohol misuse. And you can see that these groups of mothers in the top 2 lines are at substantially increased risk of having children who would then be admitted to hospital for injuries. Thankfully, these conditions are relatively rare, but the purple line here is showing mothers who live in the most deprived areas. And these mothers make up 30% of the population. So actually, the greatest population attributable risk is from this group. Even though there's only a small increase compared to the total line, they make up the largest numbers because there's so many women exposed to deprivation. So I think this, for me, highlights the need to better address the root causes of social disadvantage if we're going to think about improving children's lives. So we have, there are some of the challenges that we're facing, and to think about some of the solutions. There are initiatives that are in progress and that are being developed to help avoid the disadvantages of using data in silos and to straddle the health and non-health divide. So the first is eChild, which Cathie mentioned at the start. So eChild brings together information from hospital records, education records and social care for all children in England born since 1984. So this gives us an incredibly valuable longitudinal trajectory on 20 million children that we can now follow up. And within that, we link to maternity services data, births data, mental health services and community services data. We've got information on 8 million mothers of eChild members and 4 million clusters of siblings. So the potential for looking at relationships between siblings and household environments is really increasing. Another cohort to address some of these challenges is the Kids Environmental and Health cohort led by Pia Hardlid at UCL. This cohort will bring together information on environmental exposures in childhood and look at health and learning outcomes across the life course. So this is really going to be incredibly valuable at helping us address some of the public health challenges that we've seen in recent years or become more aware of, for example, the poor housing quality and overcrowding that was so prevalent and we understood a lot more about during the pandemic and the associated lockdowns. So these data are really going to be critical if we want to start planning interventions and improving outcomes that will have lasting impacts. So to summarise, a grand challenge in health data is thinking outside of the health box. We need to think of the wider social and determinants of health if we want to create a clearer picture of children's needs and enable these future adults to go on and live long and productive lives. We are making progress in this area in getting the data together for people to use. Both eChild and the Kids Environmental and Health cohort will be made available to researchers, eChild in the next coming months, thanks to funding from HDR UK and Kids Environment and Health cohort late 2025. But there are still missing pieces to this picture, so we need to continue to work with government and with data providers, and importantly with members of the public, to ensure that we can create sustainable research resources that can continue to be used in the future. Thank you.
Thank you very much, Catie. And now, Simon, thank you.
So, Borodar, good morning. Thank you for the opportunity to speak today. I'm Simon Thompson from Swansea University Medical School, and I've been building TREs, Trusted Research Environments, for about 11 years, and I'm co-director of the SAIL Data Bank, Dementia Platform UK, ADR Wales, and I assist HDR UK and ADR as much as I can. And I thought today, I am impressed by the quality of the speakers on stage with me today. I'm wowed by the science they're doing, but I thought I'd talk about a challenge in the sort of real world, and that's trusted research environments. They're both the answer and the challenge in my perspective, which is a bit weird because I spent my entire life building them, but they're a challenge to science itself. So obviously a trusted research environment, a data provider is convinced to put their data in a trusted research environment, and researchers enter the environment rather than giving the data out. And the Goldacre report that came out recently effectively nailed put the last nails in the coffin for the old way of giving out data, and it's universally accepted that trusted research environments are the way forwards now. And obviously now the future is going to be absolutely fantastic. Or in Wales, we have a word called bendigedig, much beautiful word than the word fantastic. All the data is going to be in TREs. It's going to be available for everybody from everywhere. There's going to be loads of science. There's going to be loads of societal benefits. It's truly going to be brilliant. However, the definition of beautiful or brilliant is somewhat different, and everybody in the entire world is building a TRE right now. They're building a better one. The best one that no one's ever thought about yet. And yet they all have the same goal, as did these folk here have the same goal initially. And yet we're in a phase of evolution, if you like, a slightly wacky racist sort of moment of evolution. I do love the enthusiasm, I do love the optimism, but I also like the fact that the IT guys are finally cool. I have now got more friends on social media than just my mother, so this is really positive for myself going forwards. And yet the religious wars have started. This is typical human nature, based on no particular rationale other than a vision of how the world should be. And I think these sort of things are going to be a huge challenge forwards. If we don't line ourselves up, if we don't stop having silly wars about silly things and concentrate on the bigger picture, I think there's going to be huge challenges ahead, quite frankly. This work came from previous QQR2, if there was such a time before that moment, where HDR UK had this maturity model. And I think whether it's this one or one going forwards, I think we're going to need something like this. We need to understand how to compare apples and pears. We need to understand what a standard for a TRE is. We need to understand what safe looks like going forwards. So we do need something to be able to judge the work that we're doing. It has started through DARE UK. The SATRA project has made great progress in this area, as some of our European friends before we left them. But I guess at least it puts TREs on the table. At least it starts the conversation. Whether this is the answer or not, it doesn't matter. We're talking about TREs. We're talking about what they are, what they shouldn't be, what they are, and so on and so forth. So that's nothing but positive in my opinion. However, market forces are going to play out. Funding is going to play out. The challenge is, how do we manage the coming and the going of TREs going forwards? How do we deal with mergers and acquisitions without disruption and without scaring the horses effectively? It's going to take a lot of courage, I think, to kind of understand that perhaps running a TRE isn't your thing and you're better off focusing on the science. A few times in the last 12 months, I've heard quite a few individuals go, "Oh, I didn't know you provided TREs. It's a shame." Well, I'm not about to go tell my board that we're not building one. It took me a year to convince to do this. And although it's going to take 12 months rather than 12 days and cost twice as much, it is what it is. And I think it takes courage, effectively, to recognize that the aspiration here is to deliver science, not to build something and own something. So siloing is potentially a big problem. Data providers obviously make a big decision to put the data in a TRE. But if we're not careful, we're going to get, with so many TREs, we're going to get data inevitably siloed into different TREs. In fact, SERP, which is the TREs that we run now, we now offer a service that if you deposit data with us, we will onwardly transmit it to other TREs. So this is a short-term gap to respond to the market needs. Now, 10 years ago, as part of the FAR Institute, if you remember all the way back then, I did a fantastic talk about castles. I do like a good castle. But it was particularly about the Safe Share project. It was well before its time, 10 years before its time, about interconnecting TREs, about talking about the possibility of silos. We were clearly wrong then, but we're right now, so that's nice. And last year, we did connect the Wales TRE and Scotland TRE, which we talked about 10 years ago. We finally achieved it last year, so that we got there in the end, I guess. So silos isn't necessarily bad, though. I don't make it like a big deal of it, because actually, if all your data that you want is in the TRE and you combine them together and take the answer out and then do the same in another TRE, you can still do great science. But of course, you have a problem if the data you want, half of it is in one TRE and half in the other. At the moment, the only real way to do this is to convince the data provider to basically put a copy in the other TRE. And that can happen also. But I guess it's going to become more and more, in my opinion, more and more of a problem. But let's also talk about the user experience, because all TREs are slightly different, and therefore, the requirements to enter the TRE, the tooling inside, they may all be functionally the same, but the user experience does vary between them. But I don't think that's a particular barrier, but it's just an observation. So unlike Blake 7, I agree that there's something in this statement. I think federation probably there is something there. However, it's completely unproven. So let's not get too excited. Let's make it work first before we declare that it's the answer to everything. Last year, we were able to do two DARE UK, which is a sister organisation to HDR UK, proof of concept projects, where I led the Teleport project, where we connected, as I say, Scotland and Wales together to kind of create business as usual TRE to TRE. And with my fantastic colleague, Carol Goby, who will be mentioned in every talk because it's the rules of the conference, who led the Triffics thing, which is about, a little bit like open safety, it's about sending the analysis out to the TREs for the answers to come back. Now, they're very, very similar, but they're hugely different also, in the sense that they're like a seesaw, these things. I mean, the key aspect is the existing governance models didn't change, because that's the only way we're going to get adoption. I think over time, an information governance model is going to have to change, but it's going to be a bigger challenge than perhaps we're facing today, because information governance can be very difficult. But if you like, in some ways, teleport is very easy for researchers, but very hard for the technical folk of a TRE, whereas Trifix is very easy for a TRE to understand and to plug in, but it does make the user experience a lot harder. Now, both of these will evolve, and I think a hybrid between these will eventually emerge to be some solution that we can take forwards. Now, the other problem with federation is it sort of destroys the existing cost recovery business model of a TRE. You guys, you clever guys, are the penguins having a nice time on top of the iceberg, and myself and a few other folk, we live underneath with the sharks and the whales. But about 80% of the energy goes into the data acquisition and the management, and there's slightly things that you would consider quite dull, but are actually really, really important to kind of enabling research-ready data sets. Market forces, however, are likely to play out now in federation in the fact that if you've got TREs and they're not all built the same, and so how do we share out the cost of running analysis across TREs? How do we share out enough cake so that these quite expensive operations can be funded appropriately? There's a real risk that if we charge per person or charge per ton of data or whatever it might be, that we're going to introduce effective bias into science. We're going to make economic decisions to exclude certain geographies or certain groups of the community. And Sara talked about it earlier about disparity. Well, in the algorithms, well, imagine if there's disparity in the data as well. That's only going to confound the problem going forward. So there is evolution happening. You know, we are bidding for a TRE at the moment where it will exist in data form only. Its entire life will be to be federated. There will be no analysis platform on top of it. But you know what? We're cheating. We're ignoring the business model. We're bidding to have it fully funded, and therefore we're sort of dodging the bullet about how you deal with the previous slide in many respects. We need to go through a lot of pain. This is what happened to Wales. It's a beautiful country. Do come and see us. Effectively, they started digging up the ground and digging underground, and then Margaret Thatcher closed everything, and we all got sad. And then we re-landscaped it, and it was all beautiful again. And then people turned up with lorries and put metal trees all over the place. But we've come to terms with it, and the farmers in Wales now are really happy growing sheep next to metal trees. But you know, we had to go through a lot of pain to get there. There was a lot of evolution. And you know what? TREs are going to have to do this. TREs today are nothing like what TREs tomorrow will be. And in some ways, we've got to have the courage to kind of be bold, really bold, I mean really, really bold, to kind of throw away perhaps all of the last 10 years of work to invent the next thing. And we have to decide whether we were going to resist this or actually we were going to embrace this. Are we going to be leaders or are we just going to moan about things? Thank you very much.
Well, thank you very much for fantastic talks. We now have some time for discussion. Not quite as much as I would certainly like, but let us crack on. So while you're thinking about questions from the floor, and do please raise your hands and be ready to ask if there's anyone who wants to ask a question. I'm just going to, I've got a couple of questions accruing already online. So for Sara, first of all, a question from Terry Emery. Are you aware of ethnic differences in willingness to agree to the use of personal data that impacts on the inequalities that you spoke of?
Yeah, that's a great question. There are differences when we spoke with people on the streets and did focus groups around this topic. And to our surprise, what we noticed was there was less disparity in willingness. There was more questioning around the reasons for data collection. And so one of our learnings from this activity and this sort of study was that there needs to be better communication and trust building and explanation of what research is, what data are used for, and people like ourselves and those who use healthcare, and that's everyone, are more than happy to contribute data. And in fact, I think there was a very sort of interesting case study that came out of the work was the patient and public interaction and engagement focus groups decided to come up with a campaign which was titled "Be Proud to Reveal Your Ethnicity When You Go to Your Healthcare Provider." So in short, that was surprisingly less of a, I think, challenge. The challenges are more around better capture, better curation, addressing the gaps and the missingness, and then training healthcare systems and providers who are to use the data, and so on.
Great. Thanks very much, Sara. So switching tack now to Mike. Mike, another question from online. What about the implications of your work? Are they pointing towards entirely computer-based models of life?
Wouldn't quite go that far. No, I think it's not really. I think one of the things that we really want to get towards is understanding, specifically modeling disease processes. That is not necessarily life itself, but we want to put all of our sort of compute and knowledge power into understanding, what A is, what changes, and then what is B, C, D, et cetera. And then how do we sort of infer what needs to happen to disrupt that process? In principle, we can do that if we have the data. But that's a long road ahead, and how do we do that in an equitable fashion is really what we're aiming at. In the process of doing that, maybe we will understand something more about life. Who knows?
Thank you. So a lot of this is about access to the right sort of data to address questions that really matter to society. So for Cathie, in terms of the social determinants of health and health-related outcomes in kids, or indeed perhaps more broadly, what difference would the ability to work with primary care data and to link that to health sources from outside or beyond the healthcare system make to some of the work that you've been illustrating?
Yeah, good question, Cathie. Yes, it would make a huge difference, because primary care data at the moment is the missing piece in eChild and in many of these data linkage projects, because it's just not possible. We've been trying for a long time, and as have you, I know, to get the permissions, the governance, the approvals in place to link in the data that do exist. They are there, the primary care data from GPs, but it's just not in a form and with under the correct governance models for us to use at the moment. But yes, we can only, and Simon's picture of the iceberg is very fitting, we can only capture the tip of the iceberg. We're not getting the full picture of health when we only look at hospital data.
Thanks very much, Cathie. Broader access is going to really transform the ability to ask the questions that matter most to all of society in a fully inclusive way. Simon, what about the role of industry in the provision of the world of TREs?
No, I think industry's got a huge part to play, I think. I think the real problem is, how do we fund industry? Because, if you like, a lot of the funding goes into science, but not a lot of funding is directed between the innovation within the development of the capability to deliver science. And whether that be academic or industry, it makes no real difference. I think the funding stream needs to be identified in order to actually attract industry and to allow the innovation from industry to be brought to bear.
Thanks very much. Okay, so getting a few arms up around the room. So I can see Piers Keane in the front row there. So can you introduce yourself briefly, and then just for those online, and then ask your question?
Thank you, Cathie. My name is Piers Keane. I'm the director of the Insight Health Data Research Hub, and I'm a professor at University College London. So I guess my comment and question was to Simon, which I enjoyed your talk about the TREs. There was one comment you made, though, that made me have a slight caution, which was that TREs are universally accepted for these things. And I guess my hesitation is that in the Goldacre report, as far as I understand it, there are a number of exceptions that they talk about. And our experience for example, using TREs for developing AI systems like deep learning systems is that currently there's a lot of problems with that, particularly if you want to make it into software as a medical device, into a specific product. And so I just wondered if you had any comments on that.
Yeah, I mean, TREs are just the here and now. I mean, really, it's all about safety. Can you do science safely for the public interest? That's the key deliverable. And at the moment, the vehicle for that is a trusted research environment. But there may, as I said, there might be other vehicles being developed or other approaches going forwards. I think AI is a really interesting one, and like the Grey Matter report and the work we're doing under the DARE project at the moment to look at how does AI models leave a TRE safely is going to be sort of really foundational, really, so that we can actually do AI and then use the model rather than you've got done a model but you can't take it out because it's too disclosive and so on and so forth. So we're not the only folk working on that, and I think it's a really important part of development that's needed to understand how to engage with AI.
Thanks, Simon. Another question over there, about 7 rows back.
Hi. So Johnny Pearson, lead data scientist at NHS England. Just wanted to ask just to Simon this one. We've heard a lot of nuances in the data in terms of the biases. We've heard a lot of, Cathie, you mentioned we need representations of data. Andrew was talking about not just creating, but also pushing out. The question is, what's the right balance of effort that we need to put into creating standardized intermediates, data models, linked data, representations of data, so that people can have easy access to those sorts of things versus giving access to the raw data and the training that people need to build from scratch all the way up? So it's a really interesting, a common data model or not, I guess is the gist of your question. And I guess I'm not a particular fan of the common data model, in all fairness. I think people have been doing fantastic science with effectively quite raw and quite dirty data, and there's some really clever people who can do some stuff with that. I think common data models, however, could accelerate science if done right, but the cost of getting there is huge. Absolutely huge. So is the business benefit of reaching a common data model worth the energy, which I guess is the premise of your question, really? And I guess it's unforeseen. I mean, OMOP is seen to be part of the answer, but when you dig into OMOP, there's a common data model, but then there are all the variations and the ontologies and the vocabularies inside. And if you deviate there, you haven't got apples and pears. You've got apples and apples. You haven't got apples and pears. So it's kind of, I think it's a really complicated area, and I think it's an area that's really worth a lot of energy into understanding if it's worth it, full stop.
Thank you very much. So we have run out of time, I'm afraid, and we are just the tip of the iceberg. So thank you so much. We've had 4 fantastic speakers. We've covered a really wide range of topics this morning. I hope we've whetted your appetites for the day ahead. And also for accosting our 4 fantastic speakers. Sara, you'll have to contact her online, and the other 3 hopefully are not going to escape too easily. So do please catch them in the coffee break and ask any further questions that you have of them, and keep talking to each other and networking. So now, having finished our session, we have a break for coffee. You've got half an hour to have a quick coffee, get out there and get back in here, because there is great excitement ahead. And I think next we're going to hear from Piers, who you've had a little kind of a snippet of, just to get a sense of what's to come. So thank you for a brilliant first session, everybody. Thanks to our speakers, and have a great coffee break.